Good morning, good afternoon, or good evening, based on where you are joining us from today, and welcome to today's webinar. My name is Laura Ceci Galanos. I am the Executive Manager of the World Stroke Academy, which is the educational platform of the World Stroke Organization, where we provide stroke education to healthcare professionals worldwide. Now, it is with great pleasure that we are hosting this educational activity on antithrombotic therapy for atherosclerotic stroke prevention, current insights and future perspectives. We have great speakers who are joining us today, and we of course want to thank Bayer AG for supporting this webinar with an unrestricted educational grant. And we also want to thank the over 700 of you who registered for today's event. Now, moving on, and before introducing today's chair, we're going to have a quick look at some of our housekeeping rules. We welcome any questions that you might have throughout the webinar, but we kindly ask you to use the Q&A box for those. So not the Zoom control, in your Zoom control panel, not the comments box, but the Q&A box, because that makes it easier for us to collect all the questions and then choose them. You can, of course, use a chat box to say hi, leave any comments, tell us where you're joining us from today. Also, a reminder that this webinar is recorded. The recording link will be sent out to you via email shortly after the webinar, and it will also be uploaded on the World Stroke Academy site. The exciting news is that alongside the webinar recording, you will also soon have access to an infographic, which will have the key takeaways from today's webinar. So a good resource for you to check. And lastly, we kindly invite you to fill in the evaluation survey at the end to share your feedback with us, because this helps us a lot to understand what it is you want to see next, and also how happy you were with the webinar, any questions we didn't get to answer, and so on. Now, without further ado, I'm going to go ahead and introduce our chair, but also our moderator for today, Professor Valeria Caso. She's our World Stroke Organization treasurer, and she currently serves as chief of the neurology department in Saronno. Welcome, Valeria, and the floor is all yours.
Thank you very much, Laura, and welcome to all of you here to our webinar. I'm very happy to share with you and with this distinguished group of speakers. We have Marta Rubera from Barcelona, Charlotte Cordonnier, and Ashkan Shobanaj from McMaster. So, you know, it's useless for me to introduce them because I'm sure that you know them all. And we are very lucky that all together they are here because they're very, very busy person and researcher. So we will start first of all with a pool. And Laura, can you share with me the pool? Okay. May I ask you to answer? These are 4 questions that we have prepared for you. And it's about your how aware you are about the current antithrombotic guidelines recommendation for ischemic stroke. How well could you prescribe how well could you describe the reason why factor 11 inhibitors are hypothesized to reduce the risk of recurrent ischemic stroke without increase of bleeding, which is clearly the higher is the risk to bleed. So why we think there is a high rationale to increase anti-inaction without increasing the bleeding risk factors. How would you describe your level of awareness about factor 11? There's a lot of talking about it. Many of you probably are also investigators of the trials. And finally, based on your opinion, please select 2 of the greatest unmet needs in secondary stroke prevention, because you know, and the speaker will clearly outline this, how high is the risk after the first ischemic event. And we know that it's already difficult to recover from a first ischemic event. The idea to have this journey once again, it's something that we absolutely need to prevent. So please vote. And we will wait for the results. Okay. Okay, so we see for the first question, no awareness, but above some average awareness. You see the second question, moderate. The main answer on slightly well, moderately well. How would you describe your level of awareness of 11? You see there is some awareness, so hopefully this will be different at the end of our talks. And there is these are your needs, so to offer a better protection, to improve, to have an improved reduction of the risk ischemic stroke, and to have an increased efficacy. So let's see what our speakers have to say about this. And without further delay, it's my pleasure now to reintroduce Marta. Marta is one of the leading stroke researcher in Barcelona from Vall d'Hebron. So the floor is yours.
Thank you, Valeria. Let me share my screen. Yeah. Okay. Can you see my screen okay? Okay. So thank you very much, Valeria, and the organizers of the webinar to invite me. I'm very glad to be here with you today to speak a bit about atherosclerosis. And as you all know, atherosclerosis is a subtype of arteriosclerosis, the hardening of the arteries that occurs when there is a growing of a atherosclerotic plaque. But we also know that atherosclerosis is a serious silent killer in the world, because more than 500 million people in the world suffer from cardiovascular diseases, and 1 out of 5 of them suffer from a stroke. In these slides, you can see the 8 standardized stroke-related dailies for vascular risk factors. And as you can see, of course, the distribution is very unhomogeneous, but I want to remark that what we have in common, the high and low income countries, is the metabolic risks being one of the most important for all of us. And on top of it is the high blood pressure, which is related to every subtype of a stroke, and especially with atherosclerotic stroke, which is the one for today. And why vascular risk factors? Here you can see a list of the classic and new vascular risk factors, some of them with higher casualty and some of them with milder. And some of them are the new targets for the new treatments that we can address. And I'm sure my colleagues will speak about more about this today. But mainly what vascular risk factors do is increase the vascular oxidative stress, and this leads to endothelial dysfunction. And this is the trigger for this very complex inflammatory disease with a very important role of LDL cholesterol, but that in the end ends up with the formation of the atherosclerotic plaque. And this is a chronic inflammatory process that starts in the beginning of the young age. With the first decade, it progresses along the years. It's a systemic disease that affects different sites simultaneously. And in the case of atherosclerotic strokes, we all know that the main atherosclerotic location is carotid, vertebral arteries, the aortic arc, and the intracranial atherosclerosis. So the classical epidemiology studies said that there almost 20% of ischemic strokes are related with atherosclerotic in the carotid artery. But more recent studies remark that especially in the Asian population, the risk of stroke related with intracranial atherosclerotic is much higher than expected. And I want to focus on this part of this graph, that you can see that the rate of diagnosis of intracranial stenosis depends more on the different diagnostic tools that we use for this study. But yes, in the Asian population, for sure, there's a high risk of intracranial atherosclerosis. And also in the white population, there are more recent studies that increase the expectation of the causality of intracranial athero in the strokes. And what is clear is that this intracranial atherosclerosis progresses with the aging. So, but for this atherosclerotic to become a symptom, a disease, the main problem is the evolution to a vulnerable plaque. And here you can see the different features of plaque vulnerability, and with different molecular patterns that can be related with this instability. And you can see this is evident that there is a very complex process with very different targets, but in the end, what leads is a quick growth of the atherosclerotic plaque, causing the occlusion of the artery and hypoperfusion of the leading territory, or a local thrombosis or embolism. In the case of extracranial atherosclerotic disease for stroke and anterior intracranial, the main mechanism is the artery-artery embolization, but in the posterior ICIs, there is a high rate of stroke related to local branch occlusions. And this can be more or less estimated through the different patterns in the MRI that we can see with the different mechanisms of a stroke. And this can also have some prognosis and therapeutic implications, as for instance, the hemodynamic compromise with this pattern may be the most indicated for being aggressive with endovascular treatments. And how can we classify atherosclerotic stroke? Well, the more used that you all know classification is the TOAS classification. This is a causative classification. It says this is the etiology of the stroke. But then there are some phenotyping classification that give us a more relative etiology, because usually there are several mechanisms that can be found in the same patient. And I just want to remark this subtype in the ASCOT that says the causal link is uncertain, that it would be classified as undetermined stroke by the TOAS classification. And that leads to the classical differentiation of the distribution of stroke subtypes. Globally, there is 1 out of 4 stroke patients that are with the main etiologies and the atherosclerotic strokes. But probably some of the undetermined strokes are also caused because of atherosclerosis, and even the small artery occlusions are in some cases caused by microtheroma. So it's much bigger than these numbers, the problem. And if we focus in the different races, and you can see again, the Asian population has a higher rate of atherosclerotic stroke. 1 out of 3 strokes in Asian population is at least caused for atherosclerosis. But even within the different races, we can see different rates if we focus in where they live. The low and middle income countries are associated with a higher risk of atherosclerotic strokes in all the different races. And this is very important because it's probably related to one of the challenges that we have today as a stroke neurologist, that is the vascular risk factors control. And what about the trend? As you probably know, in the last 30 years, there has been a reduction in the incident stroke cases and death by stroke if we look to the age standardized measurements. But with the growth and aging of the population, the absolute numbers are progressively increased. In the case of atherosclerotic strokes, in the white population, there is a trend toward a reduction in the proportion of atherosclerotic as a cause of a stroke, but there's an increase in the Asian population. And if we focus only on low to middle income countries, this reduction does not exist. And even in the Asian population, there is a higher increase of the atherosclerotic, again, remarking our problem with atherosclerotic. And then what about recurrence? I've been speaking about the incident stroke all the time, but stroke recurrence, as you know, is a very severe problem in our world, and atherosclerotic stroke has a higher early risk of recurrence that makes us be obliged to address this problem very early for the secondary prevention of our patients, but this will be spoken by my colleagues in the table, of course. So in conclusion, atherosclerosis is a systemic disease with a huge global burden. The classical and novel vascular risk factors play a key role in the development of the atherosclerotic plaques, but plaque vulnerability is the main determinant of the clinical disease. And finally, atherosclerotic strokes varies among races and populations, but there is still a very important worldwide healthcare problem that we need to address. With that, I thank you for your attention.
Thank you very much, Marta. Very interesting presentation. As we said, we will have the Q&A at the end. So you prepared the ground, and now it's the turn of Charlotte Cordonnier from Lille. Professor Cordonnier is chief of the neurology department in Lille, and very well known about her research in bleeding, intracerebral hemorrhage, and this time she will speak about emergent treatments in antithrombotic stroke prevention. The floor is yours. We don't hear you, Charlotte.
Yes, so it's really a great pleasure, and I was noticing that it nearly gives you vertigo to see how many people are joining today from all over the world. So thanks a lot for being there on Friday, whatever time zone you are. So I'm going to talk about current evidence and emerging treatments, so focusing on antithrombotic prevention. And those are my disclosures. Mainly, I was involved in two trials dedicated to factor 11A inhibitors. Those are the objectives, really considering that recurrent stroke is an issue and it's uncovered for the moment. We will focus on non-cardioembolic strokes, and especially those associated with atheroma. We will evaluate the balance between reducing ischemic events without increasing hemorrhagic complications. We'll think about the data from the large RCTs that bring important information to our daily clinical routine. What do the guidelines say, and what to do besides the choice among antithrombotic agents. So, first of all, the issue of recurrent stroke, and this is why we are prescribing antithrombotic treatment after a first ever event. And really, this is a high risk, but also a high cost situation. In the US, roughly 1 in 4 strokes is a recurrent one. And I just checked in our Lille population-based registry in the north of France, and it's about the same. 1 out of 4 patients admitted for an ischemic stroke is a recurrent one. And we've known for a long time now how this risk evolves across the time. And you've got here data from 2000 showing that progressively within the next few weeks following the stroke, you have an increase that may reach nearly 15% of risk of recurrence 90 days after the first event. I must say that most of the data that we have in the literature comes from minor stroke and TIA cohort. This is the early recurrence rate, but there's also the long-term risk of recurrence. And from a systematic review and meta-analysis on the second part of the slide, you have a long-term risk of recurrent stroke, and you can see that in some population it can reach 40%. And as Valeria Casio alluded at the beginning, recurrent strokes are associated with higher mortality, greater disability, longer hospital stays, and higher health care, but also societal care. And you imagine easily that when you already have a large sequela on your left hemisphere, when you're adding a right hemispheric lesion, your ability to compensate is much altered. So let's have a look in the rearview mirror and where are we coming from in terms of antiplatelet agent. Monotherapy has been shown with aspirin for a long time to be effective to prevent a recurrent stroke, but we also tried to find a better option than aspirin. There was trial with clopidogrel, with extended release dipyridamole, and also more recently with ticagrelor with the Socrates trial. But in the Socrates trial, it was mainly patients with atherothrombotic disease or not only ischemic stroke and not only ischemic stroke due to atheroma disease. The overall trial didn't show ticagrelor as being superior to aspirin, but if you have a look at subgroup of patients with an ischemic stroke who had ipsilateral extracranial or intracranial stenosis, as you can see in green here, this is a subgroup analysis of the Socrates trial that compared aspirin with ticagrelor. You can see that in those patients, the risk of having a recurrent vascular event was much higher when you had an ipsilateral stenosis, and this risk was decreased when you compare patients treated with aspirin and patients with ticagrelor. So gives you some insight that maybe in some selected patients, we could do better than just giving aspirin. However, in the guidelines, we mainly are going for monotherapy, except for specific subgroups. But when you look, for example, those are the American guidelines, and they tell you that in non-cardioembolic stroke or TIA, you should put antiplatelet, but they don't tell you which kind of antiplatelet you should use. You could use aspirin, clopidogrel, or even aspirin or extended release dipyridamole, but they don't help you to choose between those drugs. And really the issue is allow for how long? Well, from an evidence-based data, you can say that most of the trials sometimes went to 4 years, but in fact, what you will do is to give antithrombotic treatment lifelong. So, is aspirin in monotherapy alone enough? And if we go back to the data from the 90s, you can see that in this meta-analysis and systematic review, patients who were included in studies with a previous history of previous stroke, as you can see here, you can see that if you have aspirin compared to control, aspirin decrease your risk of future vascular event, recurrent stroke, but also MI or also vascular death. Okay, aspirin is better than nothing, but still you are around, you can see 18% of vascular risk event, which is still very much. So, is 2 anti-platelet agents better than just 1? And the first studies were focusing on long-term dual therapy in stroke patients, mainly inspired from the cardiology field. You had the MATCH study, placebo and clopidogrel versus aspirin and clopidogrel, or the CHARISMA study. But you have to take into account that when you have a long-term dual antitherapy, you see here 18 months, 13 months, inspired from the cardiology field, well, it's not effective because you decrease the risk of thrombotic event, but you increase the risk of hemorrhagic event in the brain, but not only. And this is the main difference with the cardiology field, is that the heart do not bleed, well, sometimes in poem or in the literature, but in real life, the heart do not bleed, but the brain does. So there was a need to increase anti-thrombotic efficacy without increasing too much the hemorrhagic burden. So researchers focused on short-term treatment, and this is the key. I will discuss 3 studies: the CHANCE study, short-term treatment, clopidogrel and aspirin versus aspirin, 5,000 patients, mainly from Asia. They included TIA and minor stroke, treatment within 24 hours after stroke onset, loading dose of clopidogrel of 300 milligrams. And you see it decreased, the association decreased the risk significantly of a stroke recurrence. The second study is the POINT study, coordinated in the US, but international study, short-term treatment, nearly 5,000 patients, TIA minor stroke, but the treatment was introduced within 12 hours with a loading dose around 600 milligrams of clopidogrel. And here, the study was stopped before the full sample size was completed, because the Data Safety Monitoring Board saw that there was an increased risk of bleeding in the experimental arm, and the experimental arm was clopidogrel versus aspirin. So it decreased the risk of future ischemic event, but at the cost of increasing hemorrhagic burden. And then you have a third study with ticagrelor, and this one focused on 11,000 patients. The NIHSS was slightly higher, below 5. The treatment was given within 24 hours, but once again, short-term. Sorry, I didn't mention the short-term, which was 30 days in the previous studies. And here it was also short-term, around 30 days. And you can see that you decrease also with the association of ticagrelor plus aspirin, you decrease the risk of a future vascular ischemic event, but you also increase the risk of severe bleeding. So with all that in mind, what do the guidelines say? Well, the US guideline and the European one are in line. They show you with a strong level of evidence, grade A, that the association aspirin and clopidogrel should be initiated early, within 12 to 24 hours of symptom onset, in patients with minor stroke or TIA, and continued either for 21 days if you think that your patient is at high risk of bleeding, or to 90 days in specific cases, and it's not stipulated here in the guidelines, in patients, for example, with intracranial stenosis. For the association of aspirin plus ticagrelor, the level of evidence is lower because, as I showed you, there's just one study that compare the two strategies. And it's roughly the same conclusion from the European perspective. But I must say that in real life, despite the strong data about the importance of giving strong regimen early on for 21 days, or in some selected cases for 3 months, and then you follow up with just one antithrombotic agent, antiplatelet agent, treatment gaps persist because there's very often inadequate adherence, premature discontinuation, and I think we are poorly equipped as a clinician to really address those issues. And there's also overuse of prolonged dual treatment beyond 90 days just because the family doctor forgot to stop the treatment, or because the patient didn't understand the end date. And also there's a lack of risk stratification tools because there are patients who are at high risk of bleeding and lower risk of thrombosis, and vice versa. So what does happen in real life? And I was really interested by this cohort from Italy, multicentric observational study. And really they show that in real life, dual antiplatelet therapy is used, but in much larger proportion than what has been shown in studies. As you saw previously, I said to you that the studies were focusing on people with TIA or minor stroke, NIHSS below 3 or below 5 for ticagrelor and aspirin. But in your clinical rotation, in your stroke unit, you very often see patients with more than 5 as a NIHSS within the first 24 hours. And still, most of the time, when you feel that it's due to atheroma, a lot of clinicians will prescribe the dual antiplatelet therapy, which may be associated with a higher risk of complication. And that's what was showed in this Italian multicentric study. They showed that, in fact, when you compare people who receive this dual antiplatelet therapy according to atheroma or non-atherothrombotic stroke, but I excluded, of course, cardioembolic stroke, the efficacy is the same, but the risk of any bleeding inside or outside the brain in atheroma patient is higher, significantly higher, probably because patients with atheroma ischemic stroke or have multi-comorbidity. Atheroma is a systemic disease, and it's not only concerning the brain. But there are other strategies, and I must say that this strategy, which is low-dose anticoagulation associated with antiplatelet, and maybe we could have done a poll here. I never use it in my practice, and maybe I should. While preparing this talk, I was thinking of some patients that could fit. So the COMPASS trial compared rivaroxaban, so low-dose direct oral anticoagulant associated with aspirin, and it reduced ischemic events, including stroke, in patients who were included in the study because of coronary artery disease or peripheral artery disease, but the bleeding risk increased. And once again, you decrease thrombosis, but you increase the bleeding risk. There were only 1,000 patients who had a prior stroke included in the study more than a month before randomization. But the study of the subgroup of patients with previous stroke showed that patients with the association of rivaroxaban 2.5 plus aspirin versus aspirin showed a 67% reduction in relative risk for stroke recurrence and 43% reduction in all, in MACE. And even though you pay the price in slightly increasing bleeding risk, the net clinical benefit in this population favored the combination strategy. So there's probably more to look at in this association strategy. And if we stick to antithrombotic regimen, there's probably also something to discuss, which is tailoring your choice of antithrombotic based on pharmacogenomics. You see, I don't say tailor your choice based on resistance, biological resistant test, because I don't think they are really reliable, but the genetic tailoring, especially in some cytochrome loss of function carriers, is important. And it has been shown in cardiology trials that tailoring your choice, so if you have a loss of function carrier on this kind of cytochrome variation, you switch and you replace clopidogrel by prasugrel or ticagrelor. And it's an interesting strategy in the cardiology field. It hasn't been proven in the neurological and stroke field yet. Of course, besides antithrombosis strategy, there's also the strategy of targeting inflammation. Look at the CANTOS trial, the colchicine trial, and all those new diabetic but so trendy drugs, GLP, I1RA, impossible to say, and SGLT2I. You see what I mean? But you should have a look at this literature also, and of course, and it will be the next talk, the novel class of, I'm not sure how we should call them, but factor 11 inhibitor. So to conclude, recurrent strokes remain a significant uncovered medical need, and one or two antiplatelet agents depend on stroke severity at admission. And you should limit the duration of dual antiplatelet treatment because of the hemorrhagic risk, intra and extracranial, and personalize your strategy, loss of function carriers, to use or not clopidogrel, and think about alternatives. But of course, and it's not the topic of today, but please do not underestimate all the other actions besides antiplatelet agent and besides medical treatment. And you have a few examples on the slide. Thank you very much for your attention. And if you want to come and visit Lille, we are extending the department, so there's space for you. Thank you.
Excellent. Thank you, Charlotte, and thank you for reminding us to going to run after the webinar, if time zone permits. So without further delay, I will ask Ashkan now to speak about, you have been nominated, Mr. Factor 11, you have been nominated different times, so it's your turn to give us a look to the, hopefully to the future.
Thank you very much, Valeria. And good morning, afternoon, evening, everyone, depending on where you are in this world. Thanks for joining. So next we're going to be talking about the promising potential of factor 11 inhibition to address some of this unmet need in further improving stroke prevention following particularly non-cardiomyopathic ischemic stroke, but there's still ongoing AF trials in this space as well that we'll discuss. My main disclosure being that I was the principal author of the Pacific Stroke trial, which was the phase 2 trial testing acidexine by Bayer AG, and I'm currently co-PI of the Oceanic Stroke trial that we'll discuss. So our objectives today are to, one, discuss the potential to uncouple pathologic thrombus formation from hemostasis with targeted factor 11 or factor 11A inhibition, highlight current pipeline of factor 11 and 11A inhibitors and ongoing trials, and in particular review the data supporting the potential for factor 11 inhibition for stroke prevention and the ongoing trials trying to prove that. So what's really exciting about factor 11 inhibition is that there's this potential and hypothesis that it can uncouple hemostasis from pathologic thrombus formation. In that, as opposed to hemostasis, where factor 11 has really only a minor subsidiary role, it plays a much larger and important role in pathologic thrombus formation. And the reason for that comes down to the degree of tissue factor that's released into the circulation during vessel injury or a disease state like plaque rupture. When you have vessel injury, you have a lot of tissue factor that lives in the vessel wall being exposed into the circulation, and that is sufficient to create a substantive thrombin burst to cause hemostasis. Whereas in a pathologic state, such as a plaque rupture, atherosclerotic disease, the tissue factor that's released is less. And here is where actually factor 11 provides a thrombin amplification route that generates a greater thrombin burst that we think leads to clot propagation that then translates a small thrombus into a larger pathologic one. And that's why, in comparison to a factor 10 inhibitor, where you would block, for instance, both hemostasis and pathologic thrombus formation, with factor 11 inhibition, you can maintain hemostasis while only targeting the pathologic thrombus side of this equation. And this isn't just a wishful hypothesis, in that there is substantive evidence to support it. And the actual interest in developing a factor 11 inhibitor for stroke prevention or the prevention of thrombotic events arose from observations in patients who have inherited factor 11 deficiency or hemophilia C, which is a rare form of hemophilia where patients are observed to have reduced rates of ischemic stroke and venous thromboembolism relative to the general population. And in contrast to other types of hemophilia, spontaneous bleeding, including ICH, is rather rare. People are only diagnosed during life due to elevated APTT, from menorrhagia during menses, or perhaps excess bleeding at a time of surgery, particularly when it involves certain mucosa like the oral cavity, nose, tonsils, or urinary tract. And subsequent to this, there were experimental studies in animal knockout models or mice knockout models, and then Mendelian randomization analyses that have consistently shown similar results in that factor 11 is associated, higher levels associated with excess risk of stroke, bringing it down, or having genetic determinants that bring it down, even if you don't meet criteria for hemophilia C, are associated with lower risk of stroke without excess in major bleeding. And this has led to substantial interest in developing factor 11 or 11A inhibitors. And there are 3 different compounds that are currently being tested in trials. They include antisense oligonucleotides, monoclonal antibodies, and small molecules. And in regards to our interest for stroke prevention, there have been both dose-finding phase 2 trials in AF, as well as secondary stroke prevention in patients with non-cardioembolic ischemic stroke. And now there are ongoing trials for stroke prevention in AF, as well as secondary stroke prevention, where we're focused the majority of our discussion. So the Pacific program was a program led by Bayer that looked at asundexian, which is a direct factor 11A inhibitor, in 3 disease states. That was AF, AMI, and stroke. In stroke, initially, the first study that was published looking at a factor 11 inhibitor for stroke prevention was the Pacific AF trial, where patients were 45 years of age or older who had AF and a CHA2DS2-VASc score of at least 2 for males and 3 for females were assigned to asundexian 20 milligrams or 50 milligrams daily and compared against 5 milligrams of apixaban twice daily. And the primary efficacy endpoint here was safety for major or clinically relevant non-major bleeding. And despite the 50 milligram dose of asundexian resulting in near complete inhibition of factor 11A activity, what was seen actually in this study rather, was that there was substantive reductions in both ISTH major bleeding, as was the composite of ISTH major bleeding and clinically relevant non-major bleeding relevant to apixaban, which is impressive because, of course, in similar patient populations of AFib, for instance, in the Averroes study, the rates of major bleeding with apixaban were similar to aspirin, and here we have an agent that's actually having less bleeding compared to apixaban. Similarly, a monoclonal antibody that was tested in the Azalea TIMI 71 trial also demonstrated that abilisumab, which is a monoclonal antibody, was more safe than rivaroxaban. This study was stopped early due to the greater safety of the 2 doses of abilisumab tested versus rivaroxaban 20 milligrams daily. Here, however, of course, neither trial was powered for efficacy, but I will mention that in both studies, numerically, the rate of ischemic stroke was higher in the a factor 11 or factor 11A inhibitor arm than the factor 10A inhibitor arm of these studies. For stroke prevention, as I indicated, there was Mendelian randomization analyses that further confirmed initial clinical observations of patients with hemophilia C that were subsequently validated in animal models. And what was interesting is that when you look at the association with genetic determinants of excess factor 11 levels, they are associated with cardioembolic stroke, large artery atherosclerotic disease stroke, strokes of undetermined cause. The strength of association was actually insignificant with small vessel occlusive disease, which is of interest, particularly when we talk about the results of the phase 2 trials that I'll mention to you in a second. And really the difference in stroke prevention relative to AF is that we're adding these drugs and comparing them against placebo on top of background antiplatelet therapy. And the rationale for that is this dual pathway inhibition that showed a 50% reduction in ischemic stroke that Charlotte showed us, where a lower vascular dosing of rivaroxaban, 2.5 milligrams twice daily, combined with aspirin, resulted in a substantive reduction in ischemic stroke in patients who had advanced coronary or peripheral artery disease and that had not had a recent vascular event. So the first published study was the Pacific Stroke Trial, where we tested 3 doses of asundexian, 10, 20, and 50 milligrams daily versus placebo in patients with non-cardioembolic ischemic stroke who were presenting within 48 hours of symptom onset. All patients underwent baseline MRI as well as at end of treatment or sometime between 6 and 12 months. And in total, 1,808 patients were enrolled from 23 countries. Our primary efficacy outcome in this trial was the composite of ischemic stroke or covert infarcts at 6 months, and we looked for a dose response, and this was a neutral finding. However, it became apparent to us that really the neutral finding was being driven primarily by an absence of an effect on covert brain infarcts that monopolized the majority of this combined endpoint. 75% of events were covert infarcts, not clinical strokes, and 70% of them were due to small subcortical infarcts or due to small vessel disease, where the association with factor 11 levels and stroke risk is less well established, as I had indicated earlier. When we looked at ischemic stroke in isolation, there was a suggestion of a 20% reduction in ischemic stroke with asundexian 50 milligrams, the highest dose, versus placebo. And then when we said, well, the non-clinical endpoint, MRI endpoint was neutral. What is another cerebrovascular event that we can look at in an exploratory fashion to see whether there's really this dichotomy between covert infarcts versus symptomatic events of the brain? And this is where we did this exploratory analysis of ischemic stroke and TIA. And here we did see a dose-dependent relationship between asundexian and a lower risk of this combined endpoint, and that it was reduced from 8% in those assigned to placebo to about 7.7% in those who got 10 milligrams daily, 6.2% in those who got 20 milligrams daily. And then ultimately with the highest dose, there was a robust 36% relative risk reduction that was statistically significant in this exploratory analysis. In addition, on basis of the COMPASS trial results, we're very interested in testing potential heterogeneity in the treatment effect according to patient, the presence of atherosclerotic disease as study entry. We did this in 2 ways. First, we look at the traditional TOAST criteria for patients who entered the study and met large artery atherosclerotic disease criteria as per the clinician or investigator at a particular site. Here we found that the 50 milligram dose of asundexian reduced the rate of ischemic stroke and TIA from 16% to 9%, or about a 44% risk reduction. And in particular, in those that had any degree of atherosclerotic disease on vascular imaging, there was a substantive reduction of a 61% relative risk reduction that was significant. And all these benefits, or at least suggestions of benefit, occurred without any significant excess in our combined safety endpoint of major or clinically relevant non-major bleeding. The primary analysis looked at all doses pooled together. There was this numerical excess in clinically relevant non-major bleeding that we saw that's not being shown in isolation, but that when combined with a Pacific AMI trial data that tested a similar paradigm in patients with acute coronary syndrome, there does seem to be some excess in clinically relevant non-major bleeding with this asundexian versus placebo, mind you, not aspirin, not another antiplatelet agent. We're comparing ourselves against placebo, but there is no excess in major bleeding that has been detected to date. And for all bleeding, there was also no excess risk that we identified. And importantly, when introducing an anticoagulant on top of antiplatelet therapy early after an ischemic stroke, we were interested in the rates of hemorrhagic transformation and intracranial hemorrhage in this population, and we saw absolutely no suggestion of excess risk for these endpoints with asundexian versus, again, placebo. It is worth noting that when you test aspirin versus placebo for vascular prevention, you do get excess major bleeding and clinically relevant non-major bleeding. When we test asundexian versus placebo, we don't see excess in major bleeding, but we do see excess clinically relevant non-major bleeding. But again, when it comes to major bleeding, which is of the greatest clinical consequence when you're trying to balance benefits against ischemic stroke prevention, we're actually, again, indirect comparisons that are prone to faults and limitations would suggest that these agents may be even safer than antiplatelet monotherapy. What's also reassuring is that in unison, there was a trial being led by my colleague Mike Sharma called the Axiomatic SSP trial, which was testing a different direct factor 11A inhibitor. That's milvexian. Here, to be eligible for the study, they excluded patients with acute stroke. They had to have visible atherosclerosis, and they tested a larger number of doses of milvexian. And ultimately, for their primary endpoint, which was again symptomatic ischemic stroke and covert infarcts, I'm not showing that, but that was a neutral finding, again, due to a lack of effect on the covert infarct component. When you looked at ischemic stroke in isolation, there was a suggestion of a dose-dependent response, with the exception of this paradoxical increase with a 200 milligrams twice daily dose that's still uncertain. So on the basis of these trials, there's now 2 phase 3 trials that are ongoing. Ours is the oceanic stroke trial testing asundexian versus placebo in patients with acute non-cardiovascular ischemic stroke or high-risk TIA who've been enriched for atherosclerotic disease. We've completed enrollment of this population and expect the study to complete by the end of this year. We'll be actually presenting our baseline demographics at the World Stroke Congress in Barcelona next month, and hope to be presenting our main results at a major congress next year. Libexia stroke is the other trial that's ongoing. They're still recruiting. They're testing milvexian twice daily versus placebo in a similar population. And I'll just mention that if you take these doses, 25 milligrams twice daily from Axiomatic and 50 milligrams daily from Pacific, and look at their effect in patients that have any degree of atherosclerosis on vascular imaging, so even mild atherosclerotic disease visible under CTA, you see that there's overall a suggestion of a 42% risk reduction in ischemic stroke with these drugs when used on top of antiplatelet therapy as part of this dual pathway inhibition. I'll just take a minute for Oceanic AF to indicate that this was the large phase 3 trial testing apixaban versus, testing asundexian versus standard dosing of apixaban for stroke prevention in patients with AF. And Professor Casso, who's chairing this meeting, was one of the lead PIs of this trial. And what you'll see is that this study was actually stopped early due to inferior efficacy of asundexian versus apixaban. However, the safety profile is substantive. If you look at asundexian versus apixaban and look at any bleeding outcome event, you're seeing kind of 60 to 70% or 50 to 70% reductions in ISTH major bleeding, the composite of ISTH major bleeding and clinically relevant non-major bleeding, as well as clinically relevant non-major bleeding by itself. And look at hemorrhagic stroke and symptomatic intracranial hemorrhage. You're seeing here an 80% reduction for these endpoints of greatest concern for neurologists. And I'll mention that this is not only remarkable because of the findings in patients with AF on a relative to apixaban, but as you know, apixaban has been tested in ischemic stroke populations in the Arcadia trial against aspirin. Apixaban has been tested against aspirin in the Averroes trial. in a very similar AF population. And in those settings, the rates of these bleeding outcomes were similar between apixaban and aspirin. And for hemorrhagic stroke, there's actually data that suggests that the rates were substantively numerically less on apixaban versus aspirin. And now you're seeing a drug that's providing substantively less, particularly hemorrhagic stroke relative to apixaban. But of course, so the safety hypothesis is pretty robust at this point. So we've established that. It's really the efficacy that we need to establish. And so what happened in oceanic AF? Well, perhaps factor XI inhibition is the wrong target for AF, and maybe it needs to be combined with something else to be effective. Perhaps DOACs are just too effective, and maybe factor XI inhibition should be used in comparison to a non-anticoagulant in patients who can't tolerate anticoagulation. Perhaps it's the wrong dose, and there are several ongoing trials that are testing these different paradigms. But what about our enthusiasm for stroke prevention on the basis of oceanic AF? Are we disappointed? For patients in general, yes, we're disappointed. We wanted to have a safer agent for AF. But does it reduce our enthusiasm for the positive result for secondary stroke prevention in non-cardiovascular ischemic stroke? Well, no. And the reason is that in oceanic AF, you had an active comparator. That's apixaban, very effective drug, very difficult to bleed. In oceanic stroke, we have a placebo comparator. Same with lebrexia stroke. So you're going against an inactive comparator in the stroke prevention trial, secondary stroke prevention trials. Secondly, there's absolutely no signals of efficacy in phase 2 AF trials to date with any factor XI inhibitor or factor XIa inhibitor. Whereas, as I showed you, there have been consistent signals of efficacy from phase 2 trials for secondary stroke prevention of non-cardiovascular ischemic stroke when we're using this dual pathway inhibition paradigm. Lastly, I'll say that the proof of concept for dual pathway inhibition comes from the COMPASS trial, right? This has been established in the COMPASS trial. And if you think of the dose of rivaroxaban that was used in COMPASS, it was 2.5 milligrams twice daily, a subtherapeutic dose for AF. The traditional dose for rivaroxaban AF is 20 milligrams daily, or a dose adjusted to 15 milligrams in those that have renal dysfunction. So I think all of us would agree that if we tested apixaban versus standard dosing versus rivaroxaban 2.5 twice daily in an AF population, that trial would likely be stopped early due to the lack of efficacy of rivaroxaban 2.5 versus apixaban in AF. But that does not mean that combining rivaroxaban 2.5 with antiplatelet therapy won't be effective for secondary stroke prevention. And that is the same rationale as to why we still think that what we see in AF will not have any bearing for stroke prevention or secondary stroke prevention. And what it does is it reinforces the superiority, safety of asundexian relative to traditional anticoagulants. So to conclude, factor XI and factor XIa as target for stroke prevention is supported by robust preclinical and clinical data. The bleeding profile of factor XI and XIa inhibitors is superior to factor Xa inhibitors. However, we still need to establish efficacy in stroke prevention in AF through ongoing trials. The phase 2 secondary stroke prevention trials were largely consistent in their findings and suggest a reduction in ischemic stroke recurrence, particularly in patients enriched with atherosclerotic disease. And if these results are confirmed in these ongoing trials, factor XI inhibition will establish a very exciting new paradigm that will enable us to reduce ischemic stroke without compromising safety, importantly, in patients with non-cardiovascular ischemic stroke. These are my contacts in case you want to reach out to me beyond the Q&A today, and thanks very much for your attention.
Thank you, Ashkan. Thank you, Marta and Charlotte. I think it was really a wonderful overview. We went from the atherosclerosis disease to the current indication of treatment, and then to the future of treatment. We have several questions. I think they are very interesting questions. So I will start to pick up some. For example, I think it's almost for all of you. For example, from a question from Philip Barth. Ciao, Philip. Should we consider branch atheromatous disease as part of large vessel disease? So it's very important to consider. So APT, antiplatelets, is important, or small vessel disease. So the rules of antiplatelets is less important. Is still unclear.
Thank you for an easy question from this very young stroke resident, Philippe. That's not fair. Wow, I think that's a difficult question. If I try first, in fact, I'm not sure that we can for sure identify atheroma in very small branches. So the question is first, how sure are you from of this cause? So I would target a systemic approach. If I see atheroma somewhere else, I would go for antiplatelet regimen. If I have no atheromatic disease somewhere else, I would probably not go for an intense double antiplatelet regimen. But what would you do in Spain or in Canada or in Italy?
Again, I agree with you. Sometimes it's not easy to actually differentiate it, but some location as the posterior circulation is so frequent that you found the branch occlusion as a part of atherosclerotic disease that I think it depends on where is it this small lesion that we can be more or less aggressive. But again, this is about antithrombotics, but what is common for all small vessel disease and also microatheroma is the other measures as lipid control and vascular risk factors. So maybe it's even more important in these cases, all the other things in addition to antithrombotics.
Yeah, I think that what you said about the lesion, I think this is, as neurologists, we should always remember that we know the brain and the lesion pattern is very important. So I think this is absolutely the key. What I say always to the residents, the brain is talking to you. So look at the MRI, study well the distribution, what is the lesion pattern and so on. I think this is a very important point.
I will just make a point of caution in that we've never seen any treatment interactions suggesting that patients with lacunar stroke who were included in antithrombotic trials benefited less from antithrombotic therapy than other stroke subtypes in those studies. Now, you can make the argument that the benefit in the lacunar stroke subtype was being driven by those that had branch atheromatous disease, but then you would still expect a dilution of the treatment effect in that subgroup, relative to all comers having a diluted treatment effect versus other stroke subtypes, and we haven't seen that. So although I agree that it's a compelling hypothesis, and I agree with Charlotte that we need to establish reliable criteria to differentiate who have branch atheromatous disease versus those who don't, so we can have targeted approaches in lacunar stroke patients. We know patients with lacunar stroke benefit from antiplatelet therapy. We know patients with lacunar stroke benefit from thrombolysis. So thrombosis does play a role. And again, if that benefit was being driven primarily by those that had branch atheromatous disease, you would expect a diluted treatment effect, and we don't see that. So I just want to put a word of caution out there that the fact that the prevailing sentiment that antiplatelet therapy doesn't work for true small vessel disease related ischemic strokes is still not well established.
Excellent. So another very question that I see, repeated question, is about the combination of heart disease if patient needs to have adapt for heart disease in this case, and they unfortunately have also a stroke. So how should we behave in these cases?
It's very interesting because a lot of people have in mind a concept that ischemic heart disease, coronary artery disease patients needs double antiplatelet treatment for a long time, and we see that it's not true. And in fact, there's a de-escalation strategies nowadays in cardiology, not to put those patients for too long with dual antiplatelet therapy. And what we had seen here in a cohort study in the north of France of stable coronary artery disease patients is that what predicted complication in the brain after a long-term stable coronary artery disease was the fact that they remain under dual antiplatelet while they did not needed it, and also that they have a kidney impairment. So those were the two risk factors for stroke complication, and mainly hemorrhagic stroke complication in stable coronary artery disease. So I really think that cardiologists are looking back at their habits of putting a lot of antiplatelet strategy. So
no, I think this is an excellent point. As you said, many times you see treatment going on and going on with nobody stopping it. But any point from you, Marta, Ashkan?
Well, I would add that we are also always very afraid of taking out antiplatelets in patients with with coronary stenting if we find an AF like 1 year after the coronary stenting, and actually the trend is to stop antiplatelet by cardiologists and start just anticoagulants, and that is a right thing to do. I agree with you. These patients have, if you add double or triple therapy, the risk of hemorrhage is very high. So we should be careful with that.
Yeah, I agree. And so definitely you want to ensure that you're seeing these patients in follow-up at 3 months or 1 month, whatever time point that you typically will stop the antiplatelet agent depending on the scenario, and don't just leave it to the GP, because sometimes the GPs, unless they get very clear indications to stop antiplatelet therapy, they will not do so. And again, when it comes to lacunar stroke, the timing is also very important, because we know that if you start antiplatelet therapy late, as was done in SBS3 trial, and you continue it lifelong or continuously, you do have excess mortality, right? So really, even in non-lacunar ischemic strokes, in the MATCH trial, there was no benefit and only excess harm for anything beyond 3 months. So we're really talking about DAPT for stroke prevention, this narrow initial window post an event and up to a maximum of 3 months.
Yeah. I have another important question. I think it's about factor 11. So you can all answer on this. So it's about many, the statement is many cryptogenic strokes are associated with small atherosclerotic carotid plaques producing less than 50% stenosis. Will you consider these patients for antithrombotic therapy with factor 11 medications? Maybe Ashkan, you could start.
Yeah, that certainly is a large target population in our trial. So it's going to be those patients that have ESIS, or embolic strokes of undetermined source, that have non-stenotic atherosclerotic disease, where we think we'll see a lot of benefit from dual pathway inhibition. So should the trials be positive and prove that hypothesis? Yes, definitely.
Yes. What's about, yeah, there's a question about mechanical valve. I think it's, I don't see, but you should, let me check. There was, no, sorry. I lost it. For patient, yes, with mechanical valve IF, is there a randomized trial with factor 11?
Sorry, can you repeat that question, Valeria?
Sorry, it's about patient with mechanical valve and AF, if there's a trial on factor 11.
At present, no, but because factor 11 lives in the contact pathway, which we think is involved in thrombosis with foreign devices, there is a hypothesis there that's worth exploring. But at present, there is no trials that are looking at this indication specifically that I'm aware of. I may be wrong.
Okay, and there's again a interesting question. I will not say who. should the primary in the factor 11 trials not be the composite of MACE or ischemic stroke plus fatal major bleeding? That is what will change practice.
So You can make that argument. I think we know that ischemic strokes have greater clinical relevance than major bleeds. Of all bleeding events, certainly major bleeds are the ones that are closest to the severity of ischemic stroke, but they still do not have the same level of severity. And we accept that in stroke prevention in AF, for instance. So similarly, that's the kind of rationale for separating the two and making sure that the primary efficacy endpoint is really confined to ischemic events, but certainly the primary safety endpoint, which is ISTH major bleeding, will be factored in clinical decision-making as well. But to put the whole weight of the trial on a composite when the clinical consequences of these competing events are not necessarily the same, there's arguments against taking that composite approach, and that's the path we've taken.
Thank you. Thank you very much. I think the question we are almost the most important question that we have addressed. So Laura, I think we should do again the poll. Okay, so we hope that especially about the awareness and about factor 11, there will be a change. So just once again, how aware are you of current antithrombotic guidelines for recommendation for ischemic stroke prevention? How well could you describe the reason why factor 11 inhibitors are hypothesized to reduce the risk of recurrent ischemic stroke without a corresponding clinical meaningful increase in major bleeding? 3, how would you describe your level of awareness of the current phase 3 trials? Now it should be very high, investigator factor 11. And based on your opinion, and I think this is the most important question, please select 2 of the greatest unmet needs in secondary stroke prevention. Being able to offer better protection from recurring ischemic stroke to patients who are at elevated bleeding risk, improve reduction in the risk of recurring stroke without increasing the risk of major bleeding, increased efficacy in preventing thromboembolic events, patient awareness and understanding of the benefit of adhering. We know how much important is adherence, better tools for patients to improve dietary and lifestyle management, better adherence to antithrombotic guidelines, recommendation to stroke prevention. Please vote, continue to vote. And I'm very curious about the result. So above average awareness, that's very important. So you did an excellent job, very well. So there's a change also in the percentage. How would you describe your type of awareness of the current phase 3 investigation? Very well. So important is, yes, I think this is the most important message, being able to offer a better protection from recurring ischemic stroke who are at elevated bleeding risk, because as neurologists, we know that our heart, Charlotte said this very well, our heart can bleed for other reasons, but not for anti-aggregation or other stroke prevention. And second is improved, sorry. Okay. And the better adherence to the thrombotic guidelines. Okay, wonderful. I apologize for this call, and I think Laura, you want to close the. You want to say something before closing?
We just want to thank everyone for joining. Thank you, Valeria. Thank you to Charlotte, Marta, Ashkan, excellent presentations. But thank you also to our audience who engaged with us, who answered the poll, and also for all the interesting questions. I just want to finish off with a reminder again of the 17th World Stroke Congress happening in beautiful Barcelona in October. So we are waiting for you there, 22nd to 24th. We hope to see you then. If not, we'll see you in our next webinar. Thank you, everyone.
Thank you. Bye-bye.
Thank you. Thank you very much.